course of the disease. The acute inflammatory stage usually lasts from 4 to 6 weeks. After this, the discharge is apt to change in character from a profuse thick to a thin serous flow, and the case to become subacute or chronic. The duration of the disease varies greatly. Many cases extend over a number of years. The average time for cure has been variously estimated at 4 to 6 months. In children, as in adults, gonorrhea is prone to relapse. Often, after an apparent cure, the trouble starts up suddenly and gonococci reappear in the discharge. Complications. The complications of vulvovaginitis are very numerous. Though extension of the infection to the bladder is rare in children, Wertheim has reported a case of true gonorrheal cystitis in a little girl, where the gonococcus was found in a piece of bladder mucous membrane removed by an operating cystoscope. Extension of the infection from the cervix through uterus and tubes or on into the peritoneum may give any of the surgical complications which the gynecologist finds in the adult, as salpingitis, pyosalpinx, or purulent peritonitis. These cases are often diagnosticated as appendicitis, but examination of the vaginal secretion usually reveals the gonococcus. The course of a pure gonorrheal peritonitis is usually more favorable than that of a mixed infection. Extension of the gonorrheal process to the anus and rectum may take place. Arthritis is one of the more frequent complications, gonorrheal conjunctivitis also. In fact, any of the systemic manifestations of gonorrhea may occur. Sequelae are usually adhesions of the uterus, tubes, and ovaries. Treatment. In the early stages, while there is edema of the vulva and profuse discharge, it is preferable to keep the child in bed. The mother or nurse should be instructed in the careful handling of all infectious materials. The diet should be light, avoiding any highly seasoned food, and plenty of fluid should be taken. The bowels should be kept freely open. Once or twice a day, the child should be put in a warm sitz bath. If the discharge is confined to the vulva or is very profuse there, it is well at first to confine the irrigations to the vulva only. The degree of vaginal involvement can be fairly well estimated by the method mentioned above, wiping away the pus over the vaginal opening and observing if more pus oozes down when the child cries or strains. The irrigation used for the vulva should be copious hot flushings of a 2% boric acid solution while the inflammation is very acute. This should soon be changed to a bichloride of mercury, 1 to 10,000 to 5,000 solution, Lysol, 0.5 to 1%, or potassium permanganate, 1 to 2,000. If the vagina is obviously badly involved from the first, vaginal douches should also be given without delay, the above solution, slightly diluted, being used, and 2 quarts used at a time. The best douche outfit is a soft rubber catheter, number 15 French, attached to a glass irrigating jar or ordinary fountain bag. The pressure should be mild. The child is placed in the dorsal position over a Kelly pad douche pan. The catheter should be introduced with great care so as not to injure the delicate hymen. The douches should be given twice or thrice daily, oftener if needed to wash away the discharge. After each douche, the vulva should be gently dried and ointment applied so as to protect the delicate skin from the excoriating effect of the discharge. Footnote: zinc oxide ointment has been found by some to be very useful for this purpose. Others recommend an ointment containing one of the silver salts as a 2% Prodergol ointment, Bandler. The writer has found the use of these silver ointments to be most efficacious. A light absorbent vulva dressing should be applied and held securely in place between treatments so as to avoid any conveyance of pus to the eyes by means of the child's fingers. After the first acute stage is over, the vulva should be painted thoroughly with argyrol 5 to 25%, Prodergol 2 to 4%, or silver nitrate 1%. The vagina should also have installations of any of these solutions, treatment to either vulva or vagina, being given once a day immediately following the douching. The installations into the vagina can be made readily by the use of a glass medicine dropper. Gradually, the daily treatments can be changed to thrice and then twice weekly. If the vaginitis persists, it may be necessary to give direct applications to the vaginal or cervical mucous membrane. These applications should be made with the child in the knee-chest position and by means of a small Ferguson or Kelly No. 10 speculum. The hymen should be anesthetized by a pledget of cotton soaked in 2% allopen, which is allowed to remain there for 5 to 10 minutes. Light is thrown in by means of a hand mirror and the cervix or vagina examined carefully. Erosions of the cervix or vagina can be touched up with a 3 to 5% silver nitrate solution, and if the vagina is extensively involved, it may be filled with a 1% silver nitrate solution, which is allowed to remain there for a few minutes. As improvement takes place, the silver irrigation can be replaced by zinc sulfate irrigation, solution to about 1/8% strength, or zinc and alum, 3J, to water, 0J. From time to time, the discharge should be examined for gonococci and active treatment continued so long as these are found. When the discharge no longer shows them and the complement fixation test becomes negative, a tentative cure may be pronounced and treatment stopped. In view of the tendency of the recurrences, it is wise to re-examine at intervals of months and later every year or two. Of course, this is only practicable where the physician has the cooperation of an intelligent parent or guardian.